We are so excited to have you on board for the Prompt Initiative. Of all the initiatives we've ever done, we certainly have had more enthusiastic response to this one. And I think that speaks to the recognition of the need throughout the state of Florida to address issues related to severe maternal hypertension. So thank you all so very much for joining us. And before we go any further, I do want to say thank you to all of our advisors and work group members. We put this together with the help of almost an army of you all, physicians, nurses, midwives, administrators, people from hospitals and community organizations. And the product that we are going to be sharing with you is a result of all of their work and their expertise. So we hope that it gives a good fit for what you're looking for at your facility. So let's just start off. This is our first of two data webinars, and we're going to try to make it a little bit interactive so you don't just have to listen to us. Next slide, please. There we go. Just as housekeeping, please remember to mute yourself if you're not actually speaking. Raise your hand if you have a question, or we also love questions in the chat box, and you can use the reactions, whatever is meaningful for you as you listen and have questions. And remember that the meeting is being recorded, so it will be available afterward. And if you have other team members that weren't able to join today, they should be able to watch the recording. Next slide, please. I mentioned already the enormous response to this. This is our map of where all of the Prompt hospitals are located. As you can see, we pretty much saturated the state of Florida. 91% of all the births in our state will be at hospitals that are participating in Prompt. And it's almost 90% of all the maternity hospitals in the state of Florida. There's 104, 92 of you are doing this initiative. The other 12 are also doing initiatives, just not necessarily Prompt. They may be doing 3 other things, but just not Prompt. And what we're hoping is, because of the breadth of this, because so many hospitals are working on this at the same time, there's an enormous opportunity to engage community partners and other organizations and agencies throughout the state to move the needle in a big way on hypertensive disorders for women who are pregnant and postpartum in the state of Florida. So thank you all for helping us with this. Next slide, please. So why are we doing Prompt? Hypertension is common, very common actually, but often it is very poorly controlled and underreported. And honestly, we should have also put unrecognized. Many women may have hypertension they are not aware of, certainly with chronic hypertension. Nick, can somebody click the buttons for me? Because there are more things that pop up here that are not popping. And it disproportionately affects non-Hispanic Black patients. It causes serious harm, and it is expensive. It is very expensive to treat, and it's very expensive not just for the health system and payers, but also for families who bear the burden of additional costs related to their health care and to the potential costs of an infant that ends up many times in a neonatal intensive care unit, sometimes for an extended period of time. So it's an issue that affects people in many different ways. Next slide, please. And last, we know what to do. I've worked in public health for more than 30 years, and there have been very few things throughout my career where we could say, this is an issue and this is what we can do to fix it. But we know with hypertension that there are specific things that we can do to reduce risk and reduce harm. So we are hoping to work as a statewide collaborative to act in reducing hypertensive morbidity and hopefully also mortality for women across the state of Florida. Next slide, please. Timely treatment is really important. It's a well understood best practice. It's endorsed by ACOG, and consistent implementation of treatment protocols can still be challenging. So we know that less than half of persistent acute onset severe hypertension get treated within the recommended 60 minutes. And part of that may even happen outside of your facility, right? They may have had a high hypertensive reading outside of the unit, either at home when they check their blood pressure. It could have been in their provider's office. It could have been in an ambulance and transport to the hospital. And the recommendations are that the treatment should begin within 60 minutes, and that has proved to be pretty challenging. California looked at their preeclampsia related deaths and saw that 61% of those were actually due to stroke, and that 96% of those stroke cases were preceded by a systolic blood pressure of over 160 millimeters. And the interesting thing is we have done some work over the past few months talking with EMS providers, and almost universally they said that for any other medical condition, for someone that they pick up and are transporting by ambulance, they would have not been alarmed by a blood pressure of 160 systolic or that 110 diastolic. So that was a learning curve for them. We're still going to continue to work with them throughout this initiative so that there is greater recognition, even before women get to the hospital, of the potential risks of blood pressures that are that high. And the other thing California saw in their intervention was that the chance to alter the outcome was good to strong in 66% of cases. So that means that if you acted early enough and in the right way, 66% of those cases would have had better outcomes. And that's what we want to do here. We want to improve the outcomes for women who have these severe hypertensive disorders by working together in a united way to address it across the state. And with that, I'm going to go ahead and hand off, I believe, at this next slide. We go to the next slide. Oh, I'll do this one too. Our aim for the initiative, and aim here should be A, capital A, little I, little m, because aim with all caps is usually the safer birth way they use it. But our aim for this initiative will be that our hospitals will increase by 20% the percentage of their patients that receive timely treatment for persistent acute onset severe hypertension within an hour of the first severe range reading. And that's going to be measured from the reading within the facility, not from EMS or the outpatient office. I talked about those, but that's not where we're going to measure from. And Dr. Rubio will talk about that more in a minute. And that they also get appropriate discharge education and scheduled follow-up encounters within 3 to 7 days, which is what ACOG recommends when there is a severe episode, that the follow-up encounter be within 3 to 7 days after discharge. And we're going to have the baseline be built on the first quarter of data that you enter. Next slide, please. Okay. And with that, let me introduce you.
Of course.
So, Dr. Rubio, you all heard her present at the kickoff, but I just want to say a couple of things. She is our resident expert on data and has a tremendous amount of experience in helping support hospital data needs. So not only is she skilled with epidemiology, which is looking at data across populations to look at patterns and disease processes, she's also very skilled at understanding what it means at a hospital level when you have to enter data, track data, and understand the data when you're working on a quality improvement initiative. So I just want to recognize her expertise. She's an incredible asset for our organization and brings with her a team of 2 other analysts that she'll introduce later. But with that, I want to hand off to Dr. Rubio.
Thank you so much, Lori, for those kind words. I am extremely blessed to have an incredible team. FPQC is really, truly a wonderful place to work. And it's amazing how we have the privilege to support your amazing work at each one of your facilities. And so we are very data focused and evidence-based, and we always try to look at what is available in the data so we can support your efforts better. And we base our decisions and the guidance that is out there on the data that you provide to us as well. So we are extremely thankful to you too for the effort you have in compiling and standardizing your measures so we can actually compare throughout the state. So today, as Lori mentioned, timely treatment for persistent severe hypertension is crucial to prevent severe and adverse maternal outcomes. That's why it's a major focus of our initiative. Persistent severe hypertension is a measure that allows us to track, and it's also actionable, right? Unlike getting blood pressure into a non-severe range, which can be unpredictable, especially with refractory hypertension cases, we can actually control how quickly we treat. And so our approach aligns with national guidelines, specifically the quality metric published by the Society for Maternal Fetal Medicine, SMFM, in the Great Journal. You can see here the paper, and you'll find a link in the chat in a couple of minutes. But this paper offers comprehensive guidance and explains the rationale behind the decisions in standardizing the measure, ensuring that we can compare the same thing, right, across facilities. So we are comparing apples to apples. And today we're going to focus entirely on the nuances of the measure. There's a couple of things that you may already be familiar with, but there is a couple of things that are new. So we're going to have, a couple of poll questions just to make sure that the concepts are understood. And if we need to provide additional support, we're more than happy to at any point. So just always make sure and have the confidence that you can contact us and we'll be there. So the paper will come, and the link should be in the chat in a second. But if you need it, you cannot access it for some reason, let us know. We're more than happy to share. This is open access, so we should be fine doing that as well. So let's first look at the definition of persistent severe hypertension. So we all know that severe hypertension is a systolic of 160 or more, or diastolic of 110 or more, or both, right? Either one or both. But persistent severe hypertension, which for some reason is not coming up. Okay, here, has two additional nuances. The first one, for it to be persistent, you have to have one or more repeat severe hypertension observations documented 15 to 60 minutes after episode onset. That is very, very important. And those severe blood pressure values do not need to be consecutive. You can have a non-severe event between them as long as they are up to 60 minutes after episode onset. Now, the nuance of the paper is going to be that we're also going to consider persistent severe hypertension if the blood pressure was not documented to have decreased to non-severe hypertension within 15 minutes. Or simpler said, if the blood pressure wasn't rechecked after 15 minutes of episode onset. And we have a couple of scenarios and examples to help us review these concepts, so we're going to jump into them. So the very first one, right? We want, for persistent severe hypertension, we want to have one or more repeat severe hypertension observations documented 15 to 60 minutes after episode onset, and they do not need to be consecutive. So in this case scenario, we have a pregnant patient, 32 weeks, the gestational age. She's admitted to the OBED with a BP of 170 over 105 at admission, and then 15 minutes later, she's rechecked and she's 165, 105. So if you look at the graph, that's a very simple one, right? At time 0, she has a severe event. At time 15, she has another severe event that is rechecked, that is documented. This is the best case, the easiest one to recognize, right? You have two severe ranges that are consecutive. So this is obviously a persistent severe hypertension case. Now, let's look at another case, right? You have that patient that's admitted to the OBED, same BP at admission, 170, 105. 10 minutes later, her BP is 145, 105, so a non-severe event. And then 20 minutes later, it goes back up to 175, 105. So N here does not mean normal, that means non-severe, right? So you have a severe event at time 0, right? 170, 105, and then a non-severe event at time 10, and then again, a severe event at time 30. So this is what we were meaning by saying that those values don't need to be consecutive. This is still a persistent severe hypertension case, right? Either consecutive, as in the first case scenario, or non-consecutive in this second case scenario. And the limitation here is that it's within 60 minutes, right? So if there were another case another severe event at time 70, well, that's a new episode, right? If there were no additional severe episodes within the first 60 minutes, that first event is closed. Now, in the 70 minutes, if you have another severe event, that counts as another event, not within the same as the first one. So the second nuance of the paper, as I was telling you, is that we're also going to consider persistent severe hypertension for documentation purposes, those cases where the blood pressure is not rechecked within 15 minutes, right? So we don't have documentation that the BP has decreased to non-severe hypertension within 15 minutes. The rationale here is that severe hypertension could have persisted for the entire time because there is no evidence of the contrary. And so here we're talking about burden of proof. It's on the providers to document that the blood pressure has decreased to non-severe hypertension levels by 15 minutes. If we delay in obtaining the follow-up blood pressure, that is a gap in patient safety. And the thing about this is that we can track it and we can act on it, right? That's the great thing about tracking these cases, that if we are delaying the recheck of the blood pressure when you have a severe event, that's something that we can improve. And so for documentation purposes, if you don't have a blood pressure recheck at 15 minutes, that is also going to be considered a persistent severe hypertension case. So for that scenario, right, we have a postpartum patient, 5 weeks postpartum, admitted to the OBED with a blood pressure of 165, 110 at admission, and then they didn't check at 15 minutes, they checked at 45 minutes, and it's 150, 100. So right now, when they rechecked, it was a non-severe event. However, it wasn't checked at the 15-minute mark. And because it wasn't checked at the 15-minute mark, this is also considered a persistent severe hypertension case for documentation purposes. Another example, a pregnant patient at 32 weeks is admitted to OBED. Again, the BP is 170, 105 at admission. But then this patient decides at 10 minutes she doesn't want anything to do with us and she leaves, right? Leaves AMA. And so here we have a patient at time 0 with a severe event, and then we don't have documentation of a non-severe event after that within 15 minutes. So this case is also, for documentation purposes, considered a persistent severe hypertension case, right? There's something specific about those two cases that we just reviewed. In the form that you're going to complete for your cases, you have a box where you can have, or you can provide a reason why the medication was not given or treatment was not started. You're going to have the second line that says blood pressure was not confirmed, right? So if that's the case, like for the first scenario that we saw in the second nuance, then you would check that one. Or if the patient left AMA, you would check that one as well. Or you can check both if that's the case as well, right? So the biggest thing here is that you're going to be providing the explanation or the reason why the treatment was not started, and that way we can track it and we can adjust it as we go on in the initiative. So for those that are visual learners, Texas has this very nice algorithm. I thought to share it for those that find it useful. So you have your first severe range pressure, right? So for my data abstractors, you're going to be looking at your blood pressure record. So the first thing that you're going to do when you abstract the data for this initiative is going to be identifying your cases. So you're going to be looking at patients that had a severe range blood pressure during their admission, right? And so if you find those, then the next question when you're looking at the blood pressure record is going to be, was there a repeat blood pressure check recorded within 15 minutes? Did they recheck, right? If the answer is no, then that is a fallout immediately, right? That's a persistent severe hypertension case that needs to be included for FPQC abstraction. And remember, the reason here is that the burden of proof is on us. We didn't recheck, we didn't document, we don't have it. So we are going to treat it as a persistent severe hypertension case for documentation purposes. If the answer was yes to we did recheck by 15 minutes. If the answer was yes, then the question is, was there repeat blood pressure in the severe range, right? If the answer is yes, then that's the classic case of a persistent severe hypertension case, right? You have two severe range blood pressures within 15 minutes, that's classic. If the answer is no, all of a sudden it's a non-severe range, then you continue to monitor that patient. For my abstractors, you continue to look in the BP report. And if you find any additional blood pressures in the severe range within 60 minutes of the first, then if you do, that is a persistent severe hypertension, because remember, those don't need to be consecutive. As long as you have one or more after the first one, that counts as persistent severe hypertension. And if you don't find any within 60 minutes, then the patient most likely was continued to monitor, but you will exclude those patients from FPQC abstraction, right? So again, remember, you have the first case, which is the recheck was not documented. That's going to be a persistent severe hypertension case included in the abstraction. If there is 2 consecutive documented blood pressure checks on a severe range, then that's included. And if there is a non-consecutive, but there is at least 1 or more additional severe ranges, then you also include them. If you don't find any of that, and there was just 1 severe range at the beginning, but nothing else, and the blood pressure was rechecked consistently within that first hour, then you would exclude that from the abstraction. Okay, so that's the definition and a little bit of who we are including, but there is additional information on who else we are including. We are also, for our population, we're focusing on patients that are pregnant at any gestational age or up to 42 days or 6 weeks postpartum with persistent severe hypertension. So you're going to have to look at your patients that have come to the hospital to any of the units within that range, right? Pregnant or up to 6 weeks postpartum. For the event, we are only going to include the first severe episode. And we understand that a patient may have multiple severe episodes during her admission, but for standardization of the measure, we're only going to abstract and include the first severe episode. That also helps to reduce the chart review workload. And we know that we ask a lot from our data abstractors, so we want to keep it manageable while still being informative for the initiative. And also, the paper mentions that sometimes a patient that is admitted and has multiple severe events, that may be an outlier of the team rather than the practice of the unit. So to prevent skewing our results, we're only including 1 severe event per admission rather than multiple. For the episode onset, so for the measure, we're only going to look at the first severe episode on an obstetrical unit. However, because we have been working with connections with the ED and EMS for a very long time, and many of you have done a fantastic work in connecting and maintaining those relationships, and some of you have connection to the ED and the EMS databases, you will have an option to give us the documentation of the severe range on those places, right? You can see here in the box from the data form that the patient location can be EMS, ED, OB/ED, triage, APA only, and postpartum for each one of those things that we're measuring, right? So if the first severe range was reached at either one of those locations, you can check it. And we will report that in your hospital report. However, for a statewide comparison, we're only going to use the first severe hypertension that happens on an obstetrical unit. And that's, again, to standardize our measure, because we know that some places don't have access to their EMS or to their ED documentation. So again, we are going to, track what's happening for those places that can access EMS and ED information. But for statewide comparison, we're going to track what is happening once the patient reaches an obstetrical unit. And obstetrical units include OB/ED, triage, antepartum, postpartum, labor and delivery, obviously. Right? Okay, so we have gone through quite a lot. I'm going to take a stop right now and take any questions or comments you may have for me.
There are some questions in the chat, Stephania.
Mhm.
The first one came from Bridget Funk. So to clarify, if we have a different range for severe range, which is 160 or 110, can we identify those as severe range, or do we need to use your definition of 160 or 110?
So I know that some places are using a lower benchmark. For our initiative, we're going with 160, 110. So, if you have already surpassed that, you already take care of those patients, and now you are dropping your benchmark, that's completely okay. For the abstraction, because again, we want to standardize the measure statewide, we will ask you to only include those that are 160 or more, and 110 or more. So yeah, for the abstraction, we would ask you to look at our definition and go by those numbers.
Okay,
But for
because
your own work, congratulations if you're able to go beyond the 160, 110. Bridget, go
yeah,
ahead.
it just will require me to do some different data abstraction because we follow the 160 or 100, and so I'm going to have to think about how to collect that differently then. Thanks.
No problem, Bridget. And just FYI, we are only going to ask you to submit 10 patients with severe hypertension and 5 with SMM, or as many as you have. So if you already have your report with 100, you may be able to just get your own report and just mark those that have 110 for FPQC abstraction. I don't know that that's a good solution, but hopefully that helps.
Yeah, and I would imagine we probably have 10 of them that are above the 110 anyway, so I'll just have to exclude the lower ones then. Yeah.
Perfect.
Okay.
Yeah,
thanks.
we're not asking for all the cases because that would be very difficult for many of our units. We're only asking for 10, or as many as you have. Some places don't have 10, but 10 is for those big units that may have many, many patients. We're only asking for 10. Any other questions?
Yeah, so Jennifer messaged me and just said, please confirm magnesium is used to treat as a treatment medication for hypertension management. I just wanted to get the clarification on that.
Right. So magnesium is not an antihypertensive medication. Most of you know that. It's part of the management because it's a seizure prevention medication. And for data collection, we will be tracking if magnesium was provided. Because it should be, right? At those ranges, magnesium should be part of the treatment for the episode. But just that clarification, like magnesium is not an antihypertensive drug. However, it is part of the treatment for.
So, Stefani, the reason I asked the question is the way that the slide read, it was one or the other. It should be both. And is that how the data is going to be collected, or does one meet the criteria if the other isn't given? Because that's what my worry is. A lot of times someone will put MAG on a patient, but they won't actually treat the blood pressure or treat it per the algorithm.
Yeah.
So that's seeking clarity on.
That's an excellent question. No, we are collecting information on the antihypertensives and the MAG as well. And then for the reason that the medication was not given, I think that's the one that I share with you all. We just want to assess like what is the biggest reason why the medication is not given. However, yeah, you're completely correct. Yeah, it's just part of the treatment to do MAG. But to treat the severe hypertension, definitely like the antihypertensives are listed in the paper form, and you will get it. The reason was just, a follow-up that will pop up if either one was not given separately. Mm-hmm.
Trisha asked, and I'm not sure if this is the right place to answer this, but do most set up a registry in Epic to capture this and allow the chart review to be conducted?
Yeah, that's something that you will have to work with your hospital to set up. Some places already have a report that comes out of Epic. We know that one system is already doing it and doing it well. We can always ask where it's located and how's the flow, and if it can be accessed by others. And that's part of the resources that usually with the collaborative come. But it's not part of the Epic packet. It's a report that has to be created, or you have to access through Epic to it. And we can ask this system if they are able to share. That would be the ideal thing. Most likely our units will have to go through that process, right? Establishing a way to identify these cases, and the report that comes directly from the EHR is the most ideal situation. From what I've heard from Texas, the first step is going to be to identify all the patients that have a severe range at admission, and then unfortunately, manually, you will have to see how many of them have repeat events. Or if you have a very advanced IT department that wants to take on automating the measure, that would be the most ideal thing, but I don't know of anybody that has that yet. So the report will be for identifying all the cases that have a severe range at admission, but then for the follow-ups, as far as I know, most people are doing that manually.
There are a couple of questions in the chat that are kind of asking similar things. Largely, are we needing to treat the first severe blood pressure, and is it required 1 hour from the initial blood pressure measurement or the repeat? If it's initial and the next severe is at 60 minutes, how will that work with the data collection?
So for treatment, you have to have a confirmation, right? You have to have the repeat to treat. With the first severe range, you should get ready to treat, but you have to wait until you have the recheck at 15 minutes, and then you provide the treatment once you have the confirmation. However, Margie, one of our clinical leads, would be the best ones to answer all those questions. And we do have the algorithm for everyone that is available. For data collection, we will have another section that follows this section on treatment. So I will wait until we go through that section, and then we can take questions again on treatment, if that's okay. Just because there is a couple of, again, nuances related to the paper that we have to review before we have a further discussion.
Sophia, I see that your hand's raised. You can go ahead and ask your question.
Yes, I just have a question. So if they come in the ER and the ER treats their hypertension, because sometimes they start MAG or give them antihypertensive down there, and they come up to us and they do not have the treatment is working, how do we record that? So if they're treated in the ER,
yes,
and we don't get a severe hypertension blood read when we get them upstairs, do we still wait after and retake the blood pressures? Do we run the serial blood pressures to see if they have the two, or how is that treated?
Got you. So the blood pressure needs to be rechecked consistently for the very, very closely the first hour, but then you recheck those women up to 4 hours, right, after the severe event. So
Okay.
It would depend on the timeline of the patient. You need to recheck their blood pressure when they come to your unit. And if you have a severe event while she's there, after the first hour, that would be a second event, right? We don't
Right.
track second events. Maybe your question was more related to that. If you get a second event, you don't need to submit it to FPUC. We are focusing only on the first severe event.
Okay. Thank you.
Thank you, Sophie. Great question. Are there any other questions?
Yeah, there's this is a good question. Should we skip patients that only present to the ED and do not end up in an OB unit?
So, sorry. There is two recommendations there. One, if you are able to access your ED department database and you can see what happened at the ED and you can look at the BP records, then you include it. If you are not able to, and that's a decision that you will have to do at the beginning of the initiative, right? If you're able to access what the ED did, meaning how often they checked, how the treatment went, if you can access all that documentation, then you include them. If you cannot access, you can exclude all of those because you won't have access to that information, right? In an ideal scenario, everyone should try to access their ED documentation because that is where a lot of opportunity lays. However, we understand that's not the case for every facility in the state. So that's the key. If they only come to the ED and they are discharged at the ED, but you can access the data, then you include them. If you cannot access the data, then you don't include them.
And then I think the last question is this, but if I missed your question, ping me in the chat and I'll make sure it gets answered. Is there a time limit in which the blood pressure needs to be controlled?
After a severe event, The nursing recommendations, as far as I've seen, is like 4 hours after a severe event. There's different time frames and different, how often you have to take it. And we have those resources available at the website. But for data collection, remember, we're only focusing on the first episode, and we're checking the first hour. So from the first episode onset, 16 minutes, you're checking for the records of the blood pressure within 16 minutes of the first episode onset.
Okay, and then somebody snuck in one last one. Cecile asked, do we include patients who are on antihypertensive medication already and come back to the hospital?
Yes. So we are including chronic hypertension, gestational. We're including every patient that has hypertension. That is not part of the exclusion. So yes, we're including them. That was a question that was a very great addition in the kickoff. In case you didn't hear it, someone asked, what if a patient has chronic hypertension and they come to the ED and they haven't taken their medication that day? What do we do? Do we go into the protocol, or do we give them their antihypertensive medication? And that is something that should be built into your protocol for treating severe hypertension. Most of the time, the recommendation would be that the patient takes the antihypertensive they are taking regularly. But that, again, has to be added to your protocol. For FPQC, that abstraction purposes, we are including everyone as long as they meet the inclusion criteria, which is pregnant and postpartum patients up to 6 weeks with severe persistent hypertension. All right. Any other questions? Those were great.
We have one hand raised.
Okay.
So I don't know if you're going to cover this on the 14th, but I was just looking at the measurement grid. So for O1 for severe maternal morbidity, it says patients during their birth admission. So I just want to clarify, we're saying like in terms of we wanted to figure out a way to automate this data through our system, could we just pull the patients in the postpartum unit? Because I know you've mentioned other locations as well, just for the denominator.
Yeah. Thank you for the question. So yes, that's something we'll cover next week. And that is separate from the severe hypertension measure. Those aggregated numbers for SMM, we're only asking for aggregated numbers. So yes, that's separate. So the inclusion is a little different than for the severe hypertension cases only. So the ones we're talking about today are the ones that you are going to abstract per patient. And that's why we're saying, okay, wherever they come, if you're able to access the data, you should abstract them. But for SMM, we're only asking that you include those that are needed for the birth admission, since you're only giving us an aggregated number. And I know those are, two different populations, and we do have a very detailed description in the data manual that will be available to you after the webinars. To help with that. But yeah, that's a very good differentiation. Thank you for the question.
Okay, thank you.
No problem.
We have another hand raised. Rose, would you like to ask your question?
Yes, I'm sorry, just trying to work the computer.
No
I
worries.
just wanted to clarify. I thought somebody was kind of asking this question, and I don't know if I just didn't understand the answer. So in
Sure.
our system here, sometimes our patients come in through the ED before they come up to OB triage. So if they come in through the ED and they take a blood pressure and it's a severe range, and then they call us and the patient comes up to OB/ED, are we using that severe range blood pressure from down there, or are we restarting our assessment once the patient gets up here?
So you will be reporting the time when the blood pressure was taken in the ED and also in the OB/ED. Now for treatment, you should use the time that the patient comes to the OB/ED. That's the recommendation
Okay.
from the paper.
Okay.
So for treatment, the treatment should happen 60 minutes after the onset of or once the blood pressure was checked in your unit.
Okay.
Mhm.
I just wanted to clarify that. Thank you.
No problem. Thank you so much for reframing the question. I appreciate it. All right, so we do have a little more to cover. We're gonna move forward, and hopefully we can answer more of those questions at the end. But I do have a couple of questions for you all. So there is some nuances in the paper that we want to make sure that we have addressed well. And if not, we will have to provide additional support. But I just wanted to take a brief take on how we're at with those concepts. And so poll question will come up in a second, just so you can provide the answer. And this is a scenario, you have a pregnant patient in the ED that has a blood pressure of 150, 100. And then she's admitted to the labor and delivery unit, right? Her blood pressure reading is 164, 118. No additional blood pressure measurements are taken for 25 minutes when her blood pressure reads 158, 102. So is this a persistent severe hypertension episode or case or not?
We are at 50% have answered, so we'll give y'all just a couple more seconds to answer the question. All right, I'm going to go ahead and end the poll and share our results.
Thank you, Shelby. So we have yes, 74%, no, 26%. And so for those that said yes, you got it right. So remember, the big thing here is that this patient had a severe range of 164, 118, and then no additional blood pressure checks were taken for 35 minutes. So if the blood pressure check is not checked 15 minutes after the first episode, that is immediately considered a persistent severe hypertension case, right, for documentation purposes. So that's one of the nuances of the paper, and this is one that we need to remember. So this is when the burden of proof is on documenting that the blood pressure was rechecked within 15 minutes. Since this patient was not rechecked, then yes, this is a persistent severe hypertension case. Okay, scenario 2. Please select all the cases with persistent severe hypertension. And you have in the grid basically the minutes. So episode onset is 0. So you have your severe events at time 0. And then the grid has 5-minute intervals, right? So look across and see which ones are persistent severe hypertension. And remember, N is not normal, it's just non-severe. Thank you.
And while we're waiting for everyone to fill out, to answer this question, I just want to remind everyone of our data webinar next week. We've had a lot of questions in the chat about how it will be different. And we're going to go deeper into the data collection tools, give you a demo on what it looks like in REDCap. So if you have any data collection questions about what the process will look like, we'll cover those next week. Okay, we're at 60%. I'll go ahead and share the results. Thank you all.
Thank you all. So A, 93%, B, 5%, and C, 98%. So there's 2 correct answers here. A is a non-consecutive persistent severe, right? We have the first severe event at time 0. The recheck at time 15 was a non-severe episode, which is great. But then at time 30, we have another severe event. So non-consecutive within 1 hour are still considered severe hypertensive cases. Wonderful. And then for C, which is the other one that is correct, this is the classical case, right? You have a severe event, patient is rechecked at time 15, they have another severe event. That is the classical persistent severe hypertension case. Great job. All right. Sorry, I forgot to mention, B is not correct just because you only have 1 episode of you only have 1 severe range, and then when the patient was rechecked, which is great, they were rechecked at time 15, that was a non-severe range, so that's great. And then within 60 minutes, right, we're going to continue to check within 60 minutes. Every other check was non-severe, so this is a non-severe case. All right. So scenario number 3. pretty much the same. Please select all the cases with persistent severe hypertension. All right, make sure that you made your selection. We're closing it in just a couple of seconds.
All right, hopefully you can see the results that are shared.
Thank you, Shelby. Thank you, everyone. So A got 97%, B 46%, and C 13%. So most of you got it right. And this is one that we have to remember, right? A, they have a severe event, and then this patient was not rechecked for the next hour. So this is completely immediately considered a severe hypertensive case because there's no confirmation that of what happened to their blood pressure. So we assume that they continue to be a severe hypertensive. So that's a case. And then B, you have a severe event at time 0 and then a non-severe event at time 20. But remember, the recheck has to occur at time 15, right? Since this patient didn't get recheck at time 15, that immediately falls through as a persistent severe hypertension case. And then C, fortunately, again, this patient had a severe event, but then they were rechecked within that 15-minute mark, and they had a non-severe range followed by non-severe ranges within an hour. So again, we just have to remember that if they are not rechecked or they are rechecked after the 15-minute mark, those are considered persistent severe hypertensive episodes for documentation purposes. Okay, thank you so much for participating in the poll. We do have a couple of recommendations on the treatment and considerations that we need to review. So for the measure and in the paper, we're going to look at those patients that have received appropriate treatment, right? Appropriate antihypertensive treatment. And there is 2 considerations. So the first one is that the patient received medications listed by ACOG for prompt treatment of hypertensive emergencies or agents approved in your unit protocol. And that's very important. So remember, the ACOG recommended agents are labetalol, hydralazine, and nifedipine. However, we are not prescriptive. You do have some flexibility at your facility. We hope that you will follow ACOG recommendations. I know most of you do. However, we do allow flexibility in the context that it's standardized, right? So if you add additional agents per your institutional protocol, you need to maintain a limited list of agents, and that has to be available for your data abstractor. So please make sure that in these first months of the initiative, you are working on reviewing your protocol, making sure your agents are well defined, that the dosage and timing are included. Because when the abstractor goes to check for your data, we're not asking we're asking the agent, but we're not asking the dosage or timing. We're only asking if they follow your protocol, right? So that's a yes, no question for the dosage and timing of your agent. So as you see the table below, that's what we're collecting. We have the medications, including magnesium. And then we are only asking if they follow your unit protocol. So it's very, very important that your unit works on having that ready for your abstractors prior to January. We highly discourage individual preferences for the agents. It's great when you come together and you update your protocols with agents that you may be available for your team, but we highly discourage individual preferences on that end, as those usually result in miscommunication and risks and medical errors. So that's the big ask that we have for you. Make sure that your protocol is worked out and your team agrees with it. The second nuance of the paper for appropriate antihypertensive treatment is that, of course, that these are going to be patients that receive the medications, but we're also going to look at those patients that their BP spontaneously improves to normal or non-severe without antihypertensive medication, with one important note, and that is that all subsequent blood pressures must remain non-severe within 60 minutes of episode onset, right? So the example is right here. You have time 0, you have a severe event. At time 15, the patient was rechecked. Another severe event. This is persistent severe hypertension. When they are ready to give medication, they check again, and then they see a normal, well, not normal, but non-severe range, right? So medication is withheld, which is not a recommendation, but sometimes it happens, and we are going to document that. Only if every other range is documented and non-severe, this patient may be considered as having received treatment, right? So again, only if the blood pressure checks were documented and they were all non-severe within an hour of episode onset, only then that patient would be considered as treated. And again, in your data form, you have this section where you're going to be able to check the BP improved to non-severe and all subsequent blood pressures were non-severe. So the important thing here is that you should never mark this box if subsequent blood pressures were not documented. If they were not documented, that's not a box that you should check. It's only if every single subsequent blood pressure was non-severe that you would be marking that. For the timing, and this is a question that came up in the kickoff, ACOG recommends antihypertensive treatment as soon as reasonably possible and cites literature suggesting within 30 to 60 minutes. For standardization, we're going with 60 minutes. Some places are being more strict. They have been able to do 60 minutes well, and they're moving to 30 minutes. That's completely great. However, for the state, we are looking at treatment within 60 minutes. So as long as the patient received treatment within that 60-minute mark, they would be following protocol, and they wouldn't be a fallout. Okay, so we do have a couple of next steps that are very, very important, and you all should be working on. The first one is on case identification, right? So as you think on how you're going to implement the initiative and how you're going to collect your records, one of the first things is going to be, how do you identify the patients that have persistent severe hypertension for that obstruction? And so our recommendation is that you get, if you don't have access yet, to have access to your electronic records for blood pressure measurement, and that's for your vital stats. You need to have a strategy to account for blood pressures that are witnessed or confirmed, since some of those blood pressures may be happening while the patient is contracting. So you need to make sure that your blood pressures were confirmed as being taken appropriately. The second thing is there is several ICD-10 codes that we can use to identify additional cases. The severe preeclampsia, severe hypertension, HELP syndrome, eclampsia, and pre-existing hypertension. These come from AIM. Those are used by Joint Commission as well, and that list will be available to you. So if you're working with your IT department on those reports, those codes will be handy. The other database that people are looking into is the pharmacy reports. So pregnant and postpartum patients who receive hydralazine available and or nifedipine, those pharmacy reports could be helpful in identifying additional cases. And then your debrief and data forms. So at kickoff, Margie and the team share with you the debrief form that should be implemented for all patients that have persistent severe hypertension at admission. That should be filled along with the data form at the same time. So if you are able to implement that effectively and it's used consistently, that would be a fantastic way to also keep a record of your cases. So as you create your data collection plan, you have a couple of questions that you need to answer for your own facility. One, can you access ED data, right? And we had this conversation, there were several questions about it. If you can access your ED data, then you need to start to access that information. If you need to merge data sets, work with your IT department so you can get the best out of your ED data, that would be fantastic. If you cannot, just because your hospital system doesn't allow for it, then that's completely okay. All we ask is that you remain consistent throughout the initiative. The other question is, does your facility have an updated protocol for severe hypertension? And that has to include your antihypertensive agents, dosages, and timing. That is super, super important. That is reviewed, updated, available for the abstractors. And the third thing, of course, is to partner with your health information and coders and start to build a report for case identification. All right. So do we have any questions at this point?
We have one from Vanessa, and she asked, how many subsequent non-severe blood pressures are needed?
So everything is within an hour, right? Because we're only tracking the first severe episode. Okay. So if you have a patient that had a severe episode, you're going to track 60 minutes from that first severe range. So, you know, like usually it's taken 10 to 15 minutes for the first hour.
So we only need one BPV assessment within that 60 minutes, or is the expectation to have more than just one?
So for abstraction, we're only going to ask you for the first one and the confirmation, right? But the guideline is that you check that patient, that blood pressure check. It should be happening 10 to 15 minutes within the first hour if you had a severe range.
Okay, thank you.
Yeah, no problem.
There's also a question that says, if patients are transferred out and the blood pressure is managed, are we including these?
Yes, we're including transfers.
And then Darby asked, for clarification, are we only reporting on patients who have a severe range on admission to an OB unit, or are we using the first instance of severe range on a patient at any point during their OB stay?
So at any point in their OBS stay, but it has to be the first, where you're only reporting the first.
Okay, we have another meeting for FPQC at 1. So any other questions that you guys have, please feel free to email us and we'll follow up on your questions, or you can save them for the next week's data webinar at the same time next Thursday.
Absolutely. Thank you so very much, everyone, for your attendance today. I appreciate you all. Please make sure to send us your question, and we'll see you next week. Have a wonderful afternoon.